behalf of Public Health Forum, Indian Medical Association, Karnataka State Branch, a warm welcome to all of you for today's program. The program is Cancer Early Detection Saves Life. That is Cancer Awareness Program by our renowned, famous, great human being, Dr. Appaji sir, head of the Department of Kidwai Oncology, currently the Professor, Kidwai Oncology, Bengaluru. Now I request Dr. Karunakara sir, the Honorary Secretary of IMA KSB, to do IMA prayer.
Thank you so much, Dr. Padma. With the permission of you and the President, I would like to start IMA prayer and today's function. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ, ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್, IMA ಶ್ರೇಯವಾಗಲಿ. Thank you so much. It's back to Dr. Padma. Thank you.
Thank you so much, sir. Now I request our Honorable President of IMA KSB, Dr. Srinivas sir, to deliver the presidential address.
So, good evening, everyone. So, before network problem, this is because I am at Badami now. So, anyhow, with lot of this one, I came here. Little bit network problem is there. Before any problem, I will start the program. I'll talk few words. You know that. So, and I have to great teacher as well as clinician, our Dr. Appaji sir. I know him almost 30. Immediately after entering my PG life, I know about him, and he's a fantastic personality, and he taught thousands of doctors here actually. See, every college will send the PGs to Kidwai Memorial Hospital, and he definitely, so everybody get teaching from him. So it is a very, very great opportunity for us also to arrange this. I have to thank Padma Prakash. She got this great teacher in our fold, and Dr. S.M. Prasad, our immediate secretary, past secretary. So he is also very good pediatrician. Recently he completed his pediatric presidency in IIP Bangalore. So definitely today's talk, definitely it will be more, and it will be very nice. And I have to, now I am seeing Suresh Kagalkar and Dr. Anuradha Madam, everyone I am seeing here, and my secretary also, so early he came, our honorary state secretary, Karnakar, have to thankful to him also. Everybody knows about that malignancy, very, very common in pediatrics group. All PGs used to tell that leukemias, brain tumors, lymphomas, all these aspects, and especially leukemia, one of the commonest malignancy what we are seeing. Anyhow, so our expert, the great expert is there. So definitely he is going to take, and definitely he will narrate whatever thing it is there, everything now. Thank you, sir. Thank you, Dr. Appaji sir, for you coming here and so giving talk in our Zoom meeting. And I have to thank everyone, those who assembled here. So we'll have the very good time now. So thank you one and all for giving me this opportunity also. Thank you, sir. Please proceed, Madam Padma Prakash.
Okay. Thank you so much, sir, for your kind words. Yeah. Once again, a warm welcome to all of you for this forum for today's evening. Dr. Prasad will be the chairperson for this program, but still I can't resist talking about Dr. Appaji sir, who is a BC Rayod winner, a famous, renowned oncologist who spent his 39 years service in Kidwai Memorial Institute, Bangalore. And he's a great human being, great teacher. I have no words, a shortage of words I'm falling to explain about sir. Almost all the pediatricians of Karnataka, they know about Dr. Appaji sir. Even across India also, most of the pediatricians, they know. Sir, such a simple, humble, great personality sir is. So once again, I welcome you to the program, sir. Indeed, we are blessed. We are honored to have you on this occasion. It's a very, great day for me and for all of us to have you on this platform. Once again, I want to give a warm welcome to our Honorary President, Dr. Srinivas sir, our Honorary Secretary, Dr. Karunakar sir, I think past presidents are present. Dr. Yoganand Reddy sir, Lakwal sir, Madhusudan sir also had called him over the phone, and all the dignitaries and all the viewers on this and all the fellow members of IMA KSB and all my public health forum committee members, Dr. Suresh is there, Anuradha madam is there, and all the viewers. Once again, a warm welcome to all of you, sir. Without spending much time, I'll hand over to Dr. Prasad sir. Please carry on, sir. Dr.
Thank you.
Prasad.
Thank you, Dr. Padma Prakash. This is a very wonderful program arranged by the Public Health Committee of IMA Karnataka State Branch. And really, we are happy to be associated with our IMA and all the activities, what is happening. So when we think of today's subject, that is the cancer early detection saves life. So all of us know, and all of you know about how whenever the cancer is detected very late or when the patient comes in advanced stage, definitely we feel sorry for them. When our own relatives or somebody who is close to us, or even somebody when we hear them, so definitely we feel so bad because they have been detected very early, or they couldn't approach the concerned institute like that. So definitely the treatment is more effective, and even the survival, definitely it is going to improve dramatically, suppose if the cancer is detected very early. And also we came to know that nearly 50% of the cancers are detected in the advanced stages, still now. And there are so many challenges when we think of the early detection of cancers. So there are 5 challenges. That is when we need to understand the greater about the biology and behavior of the early diseases of the cancer. And also we need to determine the risk of developing cancer, then finding and validating the biomarkers of early cancer, and also the technology, which is so much getting advanced nowadays. It is so fast, it is advanced technology in radiotherapy and all. And definitely that is a boon which is coming, at least to now, to cure the cancer or even to manage the patients who are in the terminal illnesses. And also we should know about how to appropriately, we need to evaluate our early detection. So we are really honored to have Dr. Appaji sir, Professor Emeritus from Kidwai Institute of Oncology. So he is MBBS from Mysore Medical College and MD from Bangalore Medical College, and DM in Medical Oncology, and he is from the first batch of the Kidwai Memorial Institute of Oncology. And also he has served as medical superintendent and also in charge director of Kidwai Institute of Oncology. And also we are happy to know that he is also the Shishur Ratna awardee by Indian Academy of Pediatrics, and also our Doctor's Day Award from IMA also. And also he is continuing to serve the humankind even after 39 years. So yes, sir, really we are honored to have you here. And also one more very important thing, the patients like him like anything. The service, what he gives, they have the patients himself, they have brought him back to Kidwai Institute, and he is making, he's so much proud that we are proud to have him on this platform today. And he is a role model for all of us to serve the humankind. With all our due respects from IMA KSP, we invite Dr. Appaji sir for his great lecture. We were going to get a lot of insights from his whatever his experience he is having for the last 39 years. Over to you, sir, for your deliberations.
Good evening to all. Respected Chairperson, Professor S.M. Prasad. I thank the organizers for the IMA KSP, Professor Srinivas, and Secretary Professor Karunakar, Chairperson of the Public Health Service, Dr. Padma Prakash, and Convener Suresh, to give the opportunity to share my experience on early detection of cancer in children saves lives under Cancer Awareness Program. The early detection is possible in a solid tumors, however, it is difficult in MTAR malignancies. With this few words, I will move on to my presentation.
Yes, sir. It's visible, sir. Yes. Yes, sir. Visible, sir. Continue.
Okay. This is where I am working, our Kidwai Oncology. We have a separate block for the pediatric, almost we have 100 children and housed in this building. We have the general ward, we have the emergency ward, daycare ward, along with the about 14 beds ICU. The childhood cancers constitute the 4.5 to 5% of all cancer in developed countries. However, in the West, it constitutes only 1%. The incidence of pediatric cancers 12 to 14 per 1 lakh children below 15 age in developing countries. In India, we see more than 50,000 new cases diagnosed annually. At our institute, we see more than 700 new cases registered annually. Across the world, we see more than 3 lakh children diagnosed annually. Majority of pediatric cancers are curable with a protocol-based and registered therapy. The pattern of pediatric cancers, leukemia constitutes the commonest, around 30%, brain tumor 20%, lymphoma 15%, neuroblastoma constitute are 10-12%. Others like we have soft tissue like rhabdomyosarcoma is mother tumor, bone tumors, retinoblastoma, germ cell tumor, retinoblastoma, epidermoblastoma, and LCH constitute remaining 24-30%. There are differences between childhood cancers versus adult cancers. In pediatric, leukemia, lymphoma, brain tumor are common. Almost 2/3 of the pediatric cancers are leukemia, lymphoma, brain tumors, and carcinomas are rare in pediatrics. Occasionally, we see germ cell tumor, this one carcinoma, sometimes carcinoma. Otherwise, carcinomas are uncommon. They are major bulk in adult. Majority of pediatric cancer are genetic background, and these pediatric cancers are biologically aggressive. They are more chemosensitive compared to adult cancers. The screening is not feasible pediatric because they are biologically aggressive when compared to adult. In adult, we have oral cancer, breast carcinoma, cervical cancer can detect early by screening. Causation of pediatric cancer from the fact like the physical agent, chemical agent, and biological agent rare compared to adult. And in spite of the advanced disease diagnosis, prognosis better in the pediatric, and cancer from the reproductive organ like breast carcinoma, ovarian cancer, uterine cancer, uncommon in the pediatric, but they are major work in the adult. This is the population history data. When you take the population, leukemia is the commonest, next is CNS tumor, followed by lymphomas. When you take the population history, that is, we have what you call hospital history data, leukemia commonest, followed by lymphoma, followed by CNS tumors. So there are what you call, there over a period of in the last 3 or 4 decades, the improvement in survival. It is mainly because of understanding the disease at molecular level and diagnosed tools like morphology, cytochemistry, karyotype, the phenotype, genotype to risk stratification and proper plan treatment. And third one, was referred to the cancer centers for the appropriate treatment, enroll the patient to national protocols, and available supportive care like blood component, anti-infective therapy, and our personnel change the outlook of children over a period of 3 decades. So where we stand in the outcome of pediatric cancers, that is arterial disease with tumor, they will have very high success rate, more than 90%. There are 2 diseases which are bad as of today. Acute leukemia treated with only chemotherapy, and neuroblastoma change over 1 year, which because majority percent are one disease, we have 1/3 are survive. The rest of the all pediatric cancer, we have 65 to 70%. 5 years survival. Any child survive 5 years, it is equal to cure. Chance of relapse after 5 years, 1%. So leukemias is accounts 30%, and if you have acute, we have the chronic. Acute, there is lymphoblastic leukemia, the commonest, constitute 70%, and ANL accounts 20%. The chronic, we have chronic medical 5%. We don't see chronic lymphatic leukemia in children. The disease of elderly person, usually 5th and 6th second. Coming to acute leukemia, which constitutes 70% of all leukemias, it constitutes 1/4 of all pediatric cancer, both hematological solid tumor and common age will be 2 to 6 years. And it is slightly more common boys compared to girls. They present with fever, like PUO, pallor, adenopathy, organomegaly, and hepatomegaly, joint pain, sometimes weak like rheumatic presentations, especially children below 2 years present like bony pain, mimic like pseudoparalysis, and 2 to 4% present with CNS involvement at diagnosis. The diagnostic of ALL, we do the hematite, complete blood count, look at the morphologic L1, L2, L3 blast. We do biopsy to confirm, then go for cytochemistry. We have false positive hemoblast, and TLL, they are positive for histophosphatase. L3LL, Burkitt's leukemia, they are also positive for ISLET-O. And we do karyotype synergy. There are changes circle like numeric like number to 46 chromosome, hyperdiploid. Those with hyperdiploid, the more than 46 chromosome, prognosis is good compared to hyperdiploid. And we have structural like translocation between 2 chromosomes. We have T411, T119, 1221, etc. The 1221 is one subset, they are good prognosis, and 814, 822, T28, they are associated to Burkitt's leukemia, and 1041, 14, they are associated to TLL. The 2 to 5% of pediatric ALL are the PH chromosome 922. Presence of PH chromosome carries poor prognosis. Along with the chemotherapy, we have to do tyrosine imitinib for the treatment of PH positive ALL. There are deletion can occur, then 6Q, P, 7P, 9P, etc. P stands for short arm, Q for long arm. This is the morphology of lymphoblast. They will have ions ratio coarse chromatin. This is a LTLL. They will have ions ratio, nucleus is folded, cleavage will be there. In case of Burkitt's leukemia, that is what you get is large cell with a presence of cytoplasmic nuclear vacuole, then nothing but mature B cell L3LL. The cytochemistry, we do that is a false positivity, the presence of cytoglycogen. Then we do phenotype, that is a 80% of that is a ALL are the precursor BLL, they are positive for CD19, 20, CD10, 79, CD34, HLA-DR, and TD positive. The 20% of precursor TLL, they are positive of CD3, CD7, 5, 4, 8, CD30 positive TDT. So when compared to other countries, we have more precursor TLL, only 1% of ALL, BLL, that's my L3LL, Burkitt's leukemia. That means diagnosis of ALL, we have 5 ways. One is morphology, cytochemistry, karyotype, phenotype, genotype, the 5 ways we can diagnose. This is one of our data from 2015. We have seen about 853 patients out of the precursor BLL constitute 534, precursor TLL 148, Burkitt's leukemia constitute 5 patients, and AML 152, and we have mixed leukemia, that is a B myelard, T myelard constitute about 10 patients out of 853. This is the phenotype we use to the precursor BLL, precursor TLL with a use of flow cytometry. Then we have certain subset, we go for the molecular studies. In a precursor BLL, there are many genes can have E2S6 connection is one subset with prognosis. Those with IMB21 carries poor prognosis, and those with KMTA gene alignment poor prognosis. Usually KMTA arrangement occur in the infant ALL, they will have genetically a lot of T411 translocation, poor prognosis. In a BALL, the Burkitt's leukemia, mixed gene is dysregulated. In a T cell, we have TAL1, TAL2, L1, LCK1. However, this generation we do only in case of pH positive ALL, as well as the infant ALL, we look for the KMTA2 element because the subset may require the bone marrow transplantation once with remission. Then to the biochemistry like LFTR, we cast LDH because we have to, they are more prone to tumor syndrome. We have to prevent or treat only by hydration, allopurinol, sometimes used raspberry. Chest X-ray, look for the media surrounding, any infiltration, or the NH-HLTL was got media clinical source of TLL. Ultrasound, CSF as you do for the risk stratification, CSF involved, a normal. Those CSF involved become high risk. There are prognosis factors which are described. Many prognosis factors more than 20. The example here we have 2 to 10 years. White is better, females are better, mild are better, initial count less but better, no media SMS, normal CNS, hemoglobin less than 10 gram, better, and false positive, better, morphology alone better, phenotypically because of BL better, hyperdiploid ALL better because that is a prognosis good because they can able to retain methotrexate better compared to hyperdiploid, and the the response prednisolone good. So we calculate the blast count at day 0 and we start prednisolone day 8 with the peripheral blast count less than 1000 blasts per kilometer, better compared to more than 1000. Because those blasts disappear faster, they will have ICR receptor, hence clearance is faster. They also respond to other antiplast agent. Again, nutrition plays a very important role. Good British children tolerate chemotherapy better compared to poor nutrition. And we do as of today, the MRD, say the patient with ALL complete induction therapy in 28 days, and we do 35. They have more bone marrow, not only mark for remission, but also look for the measurable disease. It should be less than 0.01%. We take a good, more than 0.01% high risk. The management of ALL is supportive, most important supportive care like the blood component, anti-infective, it may be antibiotic, antifungal, antiviral therapy, pain management, nutritional sex support. The special therapy we have across the world, treatment of ALL, same, many protocols are MCP protocol, BA protocol, and we use in our institute, ICICL protocol is one UK ALL protocol. However, usually commonly use 8 drugs in treatment of ALL, vincristine, danomycin, elaspizanase, prednisolone, cyclophosphamide, cyclophosphamide, 600 mercaptan, high-dose methotrexate. These are the 8 drugs used any protocol across the world. We have 5 phases of therapy, induction phase, lasting for 4 weeks, followed by we do the marrow, then go for conservative phase, intermittent therapy, delayed intensive phase 1, phase 2. The 4th cycle we take it as intensive phase, then it comes or runs for a period of 6 months, because every second, third child will on anti-neoplastic agent. This drug produces myelosuppression. Once myelosuppression is required, supportive care like blood component antibiotic, child should stay in or around the hospital. So after this, 4 cycles of the over, patient put on maintenance therapy, oral 6 mercaptan methotrexate tablet, and for 2 years. The total risk therapy in ALL, 2.5 years. This is one of the property data about 2005. We have treated 302 patients. The enrolled protocol that minimum follow-up, the 78% survive with this treatment, and we have 22% was mortality was there. And long-term, any child for behind 5 years, he pretty good. In this protocol, about 78% are survive. Coming to acute myeloid leukemia, it is only 20% incidence. They will have low remission compared to ALL. In ALL, we expect about 96 to 90 will go for remission with the induction therapy, but in AML, only 78% achieve remission. The 1/3 will survive. When you give only chemotherapy, that 30% survive behind 5 years. However, if you have done the transplantation in a first remission, around 6-7% long-term survival. They require more supportive care during the induction therapy like blood component antibiotic and 5,000% presentation disease or diagnosis. The difference compared to ALL. They get ALL, the fever, pallor, bleeding, they can have proptosis. Proptosis secondary to red top deposit of myeloblast, gingival hypertrophy proctitis. The DAC, which is more common in M3 subtype AML, is acute leukemia can present DAC. The investigation similar to ALL. Here we do going profile, we get a child with DAC, bone marrow for the morphology, cytochemistry, phenotype, karyotype, genotype. Here genotype look for the FLT3 mutation, NPM1. Those FLT mutation, they carry prognosis, they require target therapy in the form of sorafenib. Those NPM1 mutation is a good prognosis. Here morphologic we have M1 to M7 type. M7 type called as acute myeloid leukemia, which is more commonly seen in Down's patient. The treatment of AML, that is a non-M3 AML, M1 to M7, X7M3, we go for induction remission, we call it 3+7, 3 days of danomycin, 7 days of then do the bone marrow. Once the marrow is remission, we give option for transplant. If transplant is not possible because of the matching donor, we go for post-remission therapy with a high-dose consolidation with a high-dose cytosine. We are giving day 1, day 2, day 3, once in 4 weeks for 4 cycle. With that, we expect only about 30%. If you have done the transplantation post-remission, we expect 2/3 are long-term survival. Whereas M3 AML, we treat differently because subset can present DAC. It is not true present disease. We lose the patient the first 1 or 2 weeks because of bleeding problem. There we have to do the profile, need for appropriate to provide the plasma required for the first 1 or 2 weeks of that is a presentation. Here we go for induction. We follow donomycin plus atra is all retinoic acid is weight analog. And for the induction, once induction completed, we do the marrow for the morpho remission. We do PML-RER transcript also. Once remission, we go for the consolidation. We have once in 4 weeks 3 cycles. First cycle we have atra cytosol donomycin. Second cycle we have intrathecal cytosol atra mitoxantrone. And third cycle we have intrathecal cytosol atra cytosol donomycin. After this consolidation, we put the maintenance like ALL, 6 months daily orally, methotrexate tablet once a week and capsule atra day on day for once in 3 months for a total duration of 2 years. Like ALL, they require 2 years treatment, non-hematological require 5 to 6 month treatment. Coming to chronic leukemia, which constitutes 5% of leukemia, is one of the myeloproliferative disorders. It is a clonal neoplastic proliferation of pluripotent lymphatic cell. Here, proliferation, when you look at the marrow, we have myeloid aplasia and periblood revealed polymorphous myeloid cells in the periblood, sometimes look like leukemia reaction. The neoplastic PH chromosome is the first human chromosome described in 1960 by Nobel and Hungerford in the city Philadelphia, hence called PH chromosome. They can present with abdominal mass, abdominal pain, distension due to mass pneumonia. Here, no fever, no pallor, no bleeding current phase. Because in the acute leukemia, we have fever, pallor, bleeding common. Here, there is no fever, pallor, bleeding. Any child with a CML who present on treatment plus fever, pallor, bleeding, suggestive of blast phases. There are phase CML, they can present chronic phase, they can present agudo phase, they can present with blast phases. The workup similar to acute leukemia. Here we do karyotype, that is a 922. We do NAP score. NAP stands for neutrophil alkaline phosphatase. With the control, you have to compare. In a CML chronic phase, it decreased. Then genetically, we look for BCR-ABL transcript. It is a major transcript. The weight of the protein is 200 to 10 kilodalton. The treatment of CML, we have support like hydration, allopurinol. When the child has got very high count, patient can alter sensorium, substituted because of the high count, increased viscosity, leukothrombi, need for leukophoresis. The special therapy option today in a chronic leukemia go for drug therapy. We have tyrosine inhibitor like imitamicillate. Is one of the wonder drug changes natural history of CML. Prior to this TKI, used to treat with busulfan, hydroxyurea interferon. With availability of the imitamicillate, they survive behind 3 years median survival. And those present with blast phases otherwise may go for hematopoietic stem cell transplantation. Coming to other tumor, we have used tumor. It is the present with the 80% occur below age 5 years. It can present with abdominal mass. While giving the birth child, mother noticed some lump in the flank of the abdomen. Or abdominal mass, abdominal distension. They will hematuria, hypertension. The 15% present with the diagnosis. The common set metastasis in tumor lung. The work of the patient, other than CBC biochemistry, we go for ultrasound to lateral tumor, size of tumor, calcification, and also look for the thrombus in the renal vein IVC. Then we go for CT scan, abdomen, thorax. Later, we do the biopsy, look for the morphology, whether triphasic, biphasic, malignant tumor. Kidney has got 3 component, epithelial, blastoma, stroma. All the 3 elements is there. It is a triphasic. And 90% tumor are favorable, 10% favorable, because it's one of the curable pediatric cancer. And also we do genetic like look for 1 P deletion, P stands for short term, 1 P deletion, 16 Q deletion. This is a tumor specimen of histopathology triphasic tumor. The management of Wilms tumor, we have 3 options: surgery, radiation, chemotherapy. The policy of treatment in Wilms tumor depends upon whether the stage of the tumor, second on histopathology. The important, but favorable, unfavorable, like the anaplastic Wilms tumor, we have clear cell kidney, rhabdoid kidney, they belong to the unfavorable histology types. The treatment as and today we follow the one of the European record. SOP stands for International Pediatric Oncology. Here we plan as per the histopathology and stage. And All patients, as per the protocol, all patient will receive pre-op chemotherapy called as neoadjuvant chemotherapy with vincristine, optimizing with doxorubicin. Then after the chemotherapy, this patient go for nephrectomy. Those stage 1 low risk, we don't do any chemotherapy observation. Those stage 1 intermediate risk, stage 2 low risk, stage 3 low risk, we give two-drug combination, vincristine, optimizing for 27 days. Those stage 1 high risk, stage 2 intermediate risk, stage 1 risk, stage 4 low risk and risk, receive three-drug combination, vincristine, optimizing plus doxorubicin for 27 days. Those stage 2 high risk, stage 3 high risk, and stage 1 risk receive carboplatinum plus etoposide, alternatively cyclophosphamide, doxorubicin 37 weeks. It is one of the curable where cancer is more than 90%. This is one of the data that is minimum follow 10 years. We have enrolled or treated 50 patients. Out of that, 5 patients refused treatment, 45 patients treated. Out of that, 43 patients are alive beyond 10 years. Coming to other tumor, we have neuroblastoma. That is arise from the primordial neural cells. It comes to 10% of cancers and median diagnosis 2 years, the male predominance. It is known for regress spontaneity below 1 year. However, above 1 year, majority percent with advanced disease, hence prognosis still poor in case of neuroblastoma above 1 year. A child can present with baroptosis, they can reconcile with one of the classical presentations of the neuroblastoma, they will have periodic hemolysis. The workup other than CBC biochemistry, we go for the ultrasound, CT scan, MRI, and also we look for the, that is morphologically is one of the malignant small tumors with a, genetically look for the one deletion, double minors, and also molecular work, we look for the NMIC gene amplification. Any neuroblastoma with the NMIC amplification carries poor prognosis, irrespective of the stage pathology. Then we do the early neuroblastoma, we MHA, we have 24 hours spot test, both are same. And for the metastatic stage workup, we go for which meta will go on scan, or we go for total PET scan for the staging purpose. This is one of the round cell tumor with a presence of rosette. The treatment of neuroblastoma, as per the risk stratification, we have international neuroblastoma system. That is, we have stage 1, ESM stage 2, stage 4S. That is, the patient got early neuroblastoma with a metastatic liver, skin, or the bone marrow, we take stage 4S. And perineuroblastoma means the neuroblastoma diagnosed before 6 months. One is observation for look for any regression. If a presence of persistent disease, we go for current surgery followed by low-dose chemotherapy. The intermediate risk of neuroblastoma constitute unresectable stage 2, stage 3, infant stage 4. That is, if a patient has got disseminated disease and paraneuroblastoma, we go for pre-op chemotherapy is called neoadjuvant chemotherapy, then surgery followed by adjuvant chemotherapy plus radiotherapy. High-risk neuroblastoma, because 2/3 blood-borne disease, now the policy of treatment. And what are the high-risk stage 4 neuroblastoma children? Those with NMIC mechanism application, on histology, isoresency, go for induction chemotherapy, which consists of vincristine, cyclophosphamide, carboplatinum, hypophosphamide, etoposide combination, then surgery, consolidation with the bone marrow transplant, autologous bone transplantation, radiotherapy, followed by maintenance therapy. There is what we call it a digital antibody available as a target therapy in the treatment of high-risk neuroblastoma. Coming to other tumor, we have rhabdomyosarcoma. It is arising from the primitive mesenchymal tissues. It is the 4th common solid tumor in children and constitutes 6.5%. The clinically, histologically, genetically heterogeneity and 60% below 6 years of age, slightly more common in boys, and is one of the smaller tumor like neuroblastoma. Current multimodal therapy, risk therapy, about 70% are survive beyond 5 years. The child with a soft tissue sarcoma of the leg, they present with tumor. The workup of the CBC biochemistry, chest X-ray, go for the CT scan of the local part, then followed by the biopsy. Morphology, we have 4 types: embryonal type, alveolar type, pleomorphic, and we have spindle variant. Then confirm further, we go for immunochemistry, that requires opt-in, desmin, moiety, and genotype, we do the FOXN gene present on the chromosome in alveolar type RMS. That is, we look for the FACS3, FACS1 case of 213 allocation, FACS7, FACS1 rearrangement case of those with all RMS T113. Then do the stage workup, bone marrow. In a pyramid RMS, almost steadily constitute to 40% RMS we do CSF examination. This is a round spindle cell tumor. So management of rhabdomyosarcoma, surgery, chemotherapy, radiotherapy, and we have again risk stratification. Low risk means local RMS. After surgery, we go for that is 3-drug combination in vincristine, optimized combination. The intermediate risk will constitute local regional, all RMS, unresectable embryo RMS. Then you have to go for the 4-drug combination, VAC plus irinotecan chemotherapy. High risk, all metastatic stage 4, embryonal, all pleomorphic required, that is 6-drug, vincristine cyclophosphamide plus doxorubicin plus hyposphamide plus hydroxide irinotecan. These are the drugs we use in the treatment as per the risk stratification. This is about the data was we have about the 29 patients out of 47 because other remaining patients are advanced. Out of the 7 patients are refused, and at 5 years, that is out of 29, 22 are that is alive, about 70%, 5 survival. Osteosarcoma is one of the high-grade malignant tumors arise from the metaphyseal long bone with the presence of an osteoid. It is the commonest tumors and usually comes second decade, slightly more combines, and 80% of the patient are sarcoma present with metastases. Common sites are lung and the bone, the common site. Prior to the chemotherapy, survival only 20%. That today, with advent of chemotherapy, the more than 50% of sarcoma survive. The child present with lower end of the femur, the larger tumor, more the chance of metastasis. And the workup, other CBC blood counts, that by biochemistry, just a local part, look for osteolytic, osteoblastic changes, Cardinal's triangle, and also look for the fracture soft extension. Then to the MRI, local part, histopathology of osteoblastic, chondroblastic, fibroblastic, the type of sarcoma, bone scan, we do metastasis, and then CT scan thorax to rule lung metastasis. It is a malignant, spindle presence of osteoid. The treatment of sarcoma, we have 2 options, amputation or limb surgery. In the child for the large tumor, that is we go for amputation, one joint double tumor containing, because skip lesions known. For example, the tibia fibula go for amputation, if it's femur go for amputation. Any earlier sarcoma, we don't go for ablative surgery, we go for limb surgery, give chemotherapy, cut the tumor, put the prosthesis, limb surgery. Chemotherapy have pre-op chemotherapy, they are adjuvant, and also they practice regional chemotherapy. The chemotherapy drugs usually use 4-drug combination, high-dose methotrexate, cisplatin, erythromycin, hypothalamus drug, commonly used in treatment of sarcoma. Other we have in sarcoma bone tumor is the second common to arise from the primitive missing tissues. It arises from the diaphragm long bone. Again, it's more common in the 10 to 15 years, and it is one of the malignant forms of tumor like neuroblastoma. And again, it is a tumor before the era of chemotherapy. 5-10% survive 5 years. Today, the more than 50% survive with advent of chemotherapy. The workup include hemogram, biochemistry, chest local part. When we take a local part X-ray, we have osteoid lesion. Here we have unequivocal appearance. Whereas osteoid will have sundry appearance. Here we have unequivocal appearance. CT scan local part and histopathology, malignant round tumor. We do for the confirm immunochemistry. They are positive for NKX 2.2 and cytogenetically they are 11-20 positive, genotypically EWS gene present with chromosome 22. Bone scan for the bone involvement. Again, round tumor with a row-cell formation. The treatment in sarcoma, it is what we call it as the dose of 5,000 to 5,100. We have to irradiate hole in the bone. We call it a sinking pill technique. The whole bone will receive 30 to 40 gray and tumor bed receive 50 gray. We use 5-drug combination. It's called children protocol. The vincristine, doxorubicin, cyclophosphamide, hyposphamide for 1 year, once in 3 weeks. And those with expandable bone, like rib, the clavicle, fibula, one can do surgery. The other tumor we have, germ cell tumor, is again cause 1% pediatric cancers, arise from the primary germ cell. It occurs in the gonads, like test ovary, occurs from like intracranial, antimediastinal, retroperitoneal, sacral coccygeal. It secretes markers like alpha-4 beta-ICG. They are both diagnostic as well as of importance. They will have definite perception from the primary to the go to the region node, then to the external region. And more than 70% of one disease are curable with a cisplatin regime like Win's tumor, Hodgkin disease. Workup as a biochemistry hemogram, tumor markers like alpha-4, they are beta-ICG, and for the staging purpose, CT scan, and morphologically in pediatric, they are mainly non-surgeon like we have Yorkshire tumor and that the teratocarcinoma, eminent carcinoma, choriocarcinoma more common. Among that, most commonly Yorkshire tumor, we further confirmed by ISC and karyotype. This is Yorkshire tumor with the presence of scalar dual bodies. The management germ cell tumor, again the stratification, the testicular stage 1, that is tumor confirmed testis, we have done the myomectomy, post-op markers are normal, no further therapy. Testicular stage 1, hematuria, no chemotherapy. The interval risk, the testicular stage 2, stage 3, stage 4, ovarian stage 1, stage 2, stage 3, extragonal stage 2. We go for 3-drug combination, cisplatin, etoblomycin 3 cycle. Or if you use instead of platinum, you use carboplatinum, J for carboplatinum, etoblomycin 4 cycle. High risk are the ovarian stage 4, extragonal stage 4 receive platinum etoblomycin 4 cycle or carboplatinum based therapy 6 cycle. That means they finish about 12 to 16 weeks, they complete therapy. Coming to non-Hodgkin lymphoma, it is one of the eternal group of magnetism immune system, occurring in both immature as well as mature lymphatic tissues, constitute 5% of magnetic disease, and among the lymphoma, 60% are non-Hodgkin lymphoma and 40% disease, again common 5 to 15 years, slightly male predominance. Histologically, pediatric NHL are high grade and diffuse. Phenotypically, the 60% are the B cell, around 40% are T cell type. A child with a Burkitt lymphoma can present with magnetic swelling. The workup was done by CBC biochemistry, morpho biopsy. Histologically, we have only 4 types: lymphoblastic NHL, Burkitt lymphoma, diffuse large B-cell lymphoma, then we have anaplastic large cell lymphoma, also called K lymphoma. Further confirm we do the immunohistochemistry, they are LCA positive and do karyotype genotype. The stage workup, we do the bone marrow, CS cytology, then go for the PET scan or CT scan, neck, thorax, abdomen for the staging purposes. This is a DLBCL and the Burkitt lymphoma will present a ground cell tumor with a static appearance. It is anaplastic with the presence of, there is a high mitotic activity. The lymphoblastic is again ground cell tumor. See, treatment of NHL. Lymphoblastic NHL, we treat like AL policy for a period of 2.5 years. We use ICL protocol. Where non-blast-like Burkitt lymphoma, diffuse large B-cell lymphoma, anaplastic treat with any protocol, it is given the chemotherapy over a period of 4 to 6 months. Again, we have drugs like vincristine, dexamethasone, cyclophosphamide, idositasol, iodose methotrexate, etoposide, doxorubicin, along with intrathecal methotrexate. There was the data that is about minimum follow 10 years, about 21 patients, the 20 patients to remission, 1 patient died because of infection at 10 years, that is 80% are survived. Coming to Hodgkin disease, is one of the curable cancer, several more than 90%, and the RS cell, least number cell, is representing the cell in Hodgkin disease, and more frequent among children from developed countries. We see about an institute out of 7 patients, we see the 35 to 40 children Hodgkin disease. Again, about 4 to 5 more common boys compared to girls, and 2/3 advanced disease on our birth, 2/3 being like fever, loss of energy. In spite of advanced disease, the prognosis is very good in Hodgkin disease, and histologically, classical type of Hodgkin disease more common. The child with present with 1 year, 2 year history of neck swelling. The third probably patient might receive tuberculosis as a TB adenitis. Workup of the hemogram, CBC biochemistry, ultrasound chest X-ray, do the biopsy. Histologically, we have classical type, and then we have lymphocytic rich, lymphocytic depletion type, nodular mixillarity, and other we have nodular lymphocytic disease. And further confirm with immunochemistry, classical positive for CD15, CD30 means cluster differentiation CD, and whereas non-lymphocytic positive for CD20, CD45. We do bone marrow. Any child with anemia jaundice, we do the Coombs test. This is a child classical read stomach cell outside nucleus. It is not a strong type of Hodgkin disease. And the treatment of Hodgkin disease, we have risk stratification. The favorable risk, we have stage 1, stage 2, without B symptom, without bulky disease, we give 4 cycles of ABVD. Here, we give 2 cycles of ABVD, Adriamycin, blemlastin, we do PET scan, PET is negative, 2 more cycle. If PET is positive obstacle, we are going to go involved field radiation of 2000 rats. The interval risk, the stage 1, stage 2, with a presence of B symptoms, bulky disease, more than 3 lymph region now, we go 6 cycles of Adriamycin, blemlastin, DTC, with or without immortality. Advanced risk, that is beyond stage 3, 4, we go for 6 to 8 cycle IBVD plus or minus involved field radiation for the residual neck node, because 80% of Hodgkin disease present with neck node. This is one of the previous data, 10 years follow, 94 patients treated, out of that, 90 patients achieved CR with a 6 cycles of therapy, and number of patients, that is the relapse 4. That means 95 to 96% of the patient survive at 10 years. This is the size of the cure cancers. There are certain warning signals when to suspect pediatric cancers. In unusual lump, it is not respond to antibiotic analgesic. So rule out a possibility of, as I say, lymphomas or the any submass. Unless sudden pallor, then child is all right. Sudden pallor, if there is no obvious bleeding, we are rule out. Easy bleeding. The limping, especially below 2 years, child limping, rule out leukemia, any POs, and frequent vomiting, rule out any brain tumor. Sudden eye or vision changes, rule out any retinoblastoma. Remember, acquired squint in child to be ruled out by any possible retinoblastoma. Say implications of the what we call it as the pediatric cancers, suspicion, pathologist diagnosis. No cancer related therapy planned without histology cytology. Hence, oncopathologists play major role in diagnosis, risk stratification, prognosis. There are 2 or 3 situations you can't treat without histology cytology. One is retinoblastoma. You cannot do any biopsy, take clinical as well as radiological. You have a blastoma between the 6 months to 3 years child, you can treat. The third one, germ cell tumor with a what we call it as marker like beta cell protein. In a infiltrative Pontino-Price glioma, you cannot do biopsy, you can treat. These are 4 diseases we can treat without histology. In all the pediatric cancer required minimum cytology before starting cancer therapy. The patient thrombocytopenia splenomegaly needs bone marrow examination to load secondary. It cannot be ATP. You have seen some occasion, patient had thrombocytopenia, clinical diagnosis ATP starting steroid. Later, sometimes after 1 or 2 months, 80% neuropathy pala. No organomegaly or cytopenia needs bone marrow biopsy to confirm aplastic anemia or leukemia. The significant lymphadenopathy, pathologically reactive, needs repeat biopsy to load Hodgkin lymphoma, because 97% of disease reactive in Hodgkin disease. Only 3% neoplastic, unless you take out the lymph node, most reactive. And any malignant transfer tumor, we have nearly 10 transfer to pediatric, needs immunohistochemistry for categorization and plan proper therapy. Thank you very much.
Sir,
Tell me, sir, any questions? I'm able to answer.
Indeed, it's a very great pleasure, and we are honored to listen to your presentation on the childhood cancers, sir. So we have got some questions which have come in the chat box.
Yes, sir.
The first question, sir: has there been an increase in the childhood cancers after the recent vaccines have been administered in children?
No, sir. No, sir.
And second question, any role of biopsy in adult Wilms tumors?
So because Wilms tumor uncommon in adults, any renal mass in adult to be ruled out would be renal cell carcinoma rather than Wilms tumor. Wilms tumor will not occur in the adult. Uncommon. More commonly, the renal cell carcinoma. Probably you have to take the MRI and histopathology before going for therapy, sir.
Yes, sir. So another question. Have the alternate system of medicines have been used in the treatment and healing of childhood cancers? The role of the
No, sir.
alternate.
To my knowledge, may not much useful. Probably they are improved immune system. Probably I can say when the patient is complete therapy, one can use some other immune system therapy to improve the immune system, but may not directly attend the. However, one particular AML-M3, we use in AML-M3, use Atra plus donomycin for the treatment. It's a different agent. Probably they use arsenic also in the treatment of AML-M3. Probably one other treatment they use gold, mercury, other things helps in differentiation. Only AML-M3, probably in a subset of M3-AML may benefit it, sir.
And another question, sir. What's the treatment protocol after relapse?
What, sir?
What is the treatment protocol after relapse?
Say any relapses, say we suggest for the patient, as of today, the duration of treatment in pediatric cancer varies from the 12 weeks to 2.5 years. The example, Zemsted tumor, they complete by 12 to 15 weeks. Acute leukemia require 2.5 years therapy. Rest will require less than 2.5 years, more than 12 weeks. Then we follow 3 years post-therapy for any relapse. If there is no relapse, 3 years post-therapy, we take it as cure. After 3 years of therapy, only 1%. Any relapses, early relapse, during treatment, prognosis poor, sir, but we have to go for salvage chemotherapy. One option is go for hematopoietic stem cell transplantation. However, late relapse, still we can attempt some chemotherapy, over 30-40% chance. Early relapses, prognosis grave in spite of going for salvage chemotherapy or with the transplantations.
Sir, one more question from the same audience. What is the cost of treatment for a child with cancer? What are the supportive systems available?
Say in our institute, we are, because all BPL patients enrolled under the Ayushman Bharat scheme, no money, sir. Now everything is free, but however, that depending upon the different tumors we have. Example, acute leukemia, 2.5 years may cost around 4 to 5 lakhs rupees in a private setup, sir. Example, Hodgkin disease, probably we can finish by 30 to 40,000 rupees. Different cancer law, different protocol-based therapy, depending upon only ALL required. As well, acute leukemia required, costlier. Rest therapy can give depending upon the protocol we use, stage we use, risk stratification, sir.
And one more question has come, sir. Dr. Geeta Dopa from, I have an antenatal patient whose first child has retinoblastoma. Now, she is at early pregnancy. She is worried about the second baby. Will it be affected like that?
So now it is a need for the screening, sir, because first child we don't know whether unilateral, bilateral, what they've done is karyotype, whether done the RBG mutation, we have to see, sir. But when the child has got, there is a first child has got retinoblastoma. In the second subsequent pregnancies, we have to go with alternate screening. We have to go amniocentesis or chorionic biopsy to be ruled out any the RBG mutations, sir.
And these are the questions which we have been received from the chat
Sir,
box.
one more, sir. Shalaka Maharaja. Excellent presentation, sir. You are an inspiration for so many. And Gautam, very useful information. Thank you so much, sir.
And any tips, sir? Because we have got audience here and delegates here who are attending. Like they are from different specialties, sir.
Yes, sir.
From general practice to different specializations. So what is your say to when to refer?
Say, what I would say, pediatric cancers are now curable with available treatment. Across the world, treatment is same, sir. What is there available in the developed country, available in the India also. And again, there is a example, any lymph node mass now to treat without histology, because sometimes recently we have seen child were diagnosed as TB lymphadenopathy, patient put on ATT, disease progressed. Any lymph node persists beyond 3 to 4 weeks, not respond to any antibiotic. Do the biopsy, confirm whether tuberculosis, not tuberculosis, then you have to treat appropriately. Second one, any joint pain, not responding to this one. If they have some thrombocytopenia, rule out possibility of leukemia because leukemia is the commonest. The third most important, that is child with, because brain tumor is the second commonest periodic cancers. Any child with seizures, not related to couple episodes. Seizure, which is not related, any seizure post that is digital, the deficit probably ask for CT scan or MRI, sir. Rule out in intracranial tumors. And any child with the low platelet, if he has got sphenomegaly, it can't be ITP. It should be secondary purpura. Rule out whether viral infection or something neuropathology like leukemias. We have seen many occasions the ITP diagnosed as the ALL diagnosed ITP treated, rheumatoid arthritis diagnosed as the ALL present joint pain diagnosed as rheumatic arthritis.
What about the usefulness of bone marrow transplantation in which are all the conditions where it can be used in?
Now there are 2 or 3 conditions one can go for transplant. By this one, any acute mild leukemia with chemotherapy only 30%. One should concentrate AML, one such remission, go for either matching donor available, allogeneic transplantation one, sir. Iris neuroblastoma patient that is stage 4 disease with all chemotherapy 120%. If you have done the transplantation along with the target therapy, around 40-50% survive. And third one, Hodgkin disease relapse, one can do transplantation. Hodgkin disease, upfront, no transplant, only chemotherapy. If they relapse after chemotherapy, go for transplant. Iris neuroblastoma and acute mild leukemia are the 3 conditions one can go for transplantation.
And what is the earliest stage the cancer is detected in children?
Even you have seen 1 month old child also, 1 month also.
1 month also.
Infant neonatal leukemia.
Any other questions from the audience?
Questions we have
I think Dr. Madhusudan Karagnur and Yogendra Reddy sir, they've joined. Dr. Veena, Dr. Suri Raju is there.
Illa, Padma. Nothing.
Can I just ask one question, Dr. Prasad?
Yes, sir, please, madam. Please.
Have there been any cancers detected in the womb of the fetus?
So teratoma can be detected, madam. Sacral teratoma may be diagnosed in utero, madam. They can present with a sacral coaxial mass. One can diagnose intrauterine.
Okay.
Dr. Sandhya Rani, Kirti, any other questions? Thank you so much, Dr. Appaji sir, for your elaborate and such an enlightening talk regarding these cancers, especially the pediatric cancers. Being a student, I worked there in Kidwa Oncology for 1 year. So I can feel, I could sense the statistics, what you have done, especially the ALLs. And I know that, yeah, leukemic patients have been cured. They have become doctors, engineers. They have been married, having normal children. That is a great credit. A big salute to you, sir, because you are really divine. Given treatment to patients, whatever LRTA, URTA, doing a lot of surgeries. Of course, it matters being doctors. But you have given life to the patients with leukemia. They are becoming professionals, having normal children. It is very much divine. I have no words. I'm running shortage of words to express the things. So I personally feel that I'm being blessed that I worked under you to have you as a great teacher in my life, sir. Thank you once again for joining our invitation of IMA KSB. And you delivered such a wonderful talk to all the audience. Hope all the audience will take the necessary information what you gave to you. And I think Dr. Srinivas sir is there. Dr. Karunakara sir. Shall we come to the end of the program, sir?
I think they are traveling.
Yeah, you can conclude, Padma.
Okay, thank you very much, sir. I think we are coming to the end of the program. Vote of thanks
Dr.
from
Padma.
Dr.
Yeah, you can go ahead. Very nice program, Padma. Hello?
Yeah.
You just keep it, it
Can you hear me?
it melts.
Yes,
It
yes, I can hear
Yeah,
you,
I
sir.
heard. Yeah, I heard.
You host it.
I heard and I.
It is the worst fish to have.
You can go ahead, no problem.
Like that much.
No.
Do you take this?
Some audio disturbance is there, sir. Dr. Suresh Kagalkar, please deliver vote of thanks.
Good evening, everyone. Now we'll come to the end of the session. After having a wonderful presentation, we have got we felt that something, many of the babies, many of the children, after seeing the slides, various slides we have seen, like with the tumor, with the various pictures. So in the some of the slides, we came to know that the alive and survival rate is very good as per the figures. So we felt very happy. Sir has got a lot of experience, and sir has accepted our invitation. And with due respect, once again, I thank to Dr. Appaji Gowda sir, who has deliberated a very good topic, and it is very important for all the clinicians. So once again, I thank Appaji Gowda sir. You have come to the IMA KSP and Public Health Forum, and it is very good topic. Thank you once again. Thank you, sir. Thank you. And on the behalf of IIM KSP Public Health, I must give thanks to our beloved president, Dr. Srinivas sir, who has given opportunity in his busy schedule. He came and joined and has given advice to the public health. So we are doing every month with a different speaker, with a different topic. Thank you very much, Srinivas sir. And also, I must say thank to our beloved Secretary, Dr. Karunakar sir, who is always will be there and he is supportive for all our programs, especially public health program. And we are doing with your support and your ideas. Thank you, Karunakar sir. And also, I must say thank you to today's chairperson, Dr. Prasad sir. So no one to say because sir is a part of IMA and he has served as a secretary, honorary secretary of IMA KSP in the previous year. And also he is a professor of pediatrician, and he is also experienced, and with his chairmanship, it is a very well conducted such a important topic, and the good speaker also. Thank you very much, sir, for conducting such a wonderful program, Prasad sir. And I must say thank you to the Yogananda Reddy sir who has joined, and Anita madam, Madhusudan sir, and I must say thank you to everybody who has joined. Lakul sir also joined. Anuradha madam has asked many questions, and Veena madam, all the chairpersons of the different our wing, IMA KSP, and Geeta Dappa madam also joined, our chairperson of the IMA KSP, and Nagbhushan sir, Ravindra sir, and Suri Raju sir, he's a urologist, and Rajendra Prasad sir. So everyone, I must say thank you, and all the viewers, YouTube viewers, I must say thank you.
Padma also.
Yeah, our without leaving, I must say thank you to our chairperson, Dr. Padma Prakash, who has given opportunity to conduct such a program, and also he has selected voluntarily, and with his experience, Madam has selected a star of the program, Dr. Appaji Gowda, who in his busy schedule accepted. And thank you very much, Madam, and as well as Appaji Gowda sir also once again. And we will continue such programs in the next month also with the different
Thank
programs.
all the participants.
And
the
all the
audience.
participants, all the viewers, all the participants, and all the student of Appaji Gowda sir, and all the well-wishers of the IMA KSP who has joined, irrespective of the any members and any our subcommittee. So everyone, I must say thank you, and thank you again. Once again, join to the next month with a different topic and the different speaker. We will arrange in a different way, especially the women health. World Women's Day is coming. Anuradha madam is there, and we'll do a good, important, good program, so that we'll remember every year the KSP, especially Public Health Forum, is doing. Thank you once again. Thank you. Good night, sir. Good night, everyone. Good night, madam. Good night, everyone. Thank you, sir. Thank you.
Thank you,
Namaste.
Appaji sir.
Good night.
Thanks, everyone. Thanks,
Dr.
everyone.
Suresh.
Namaste, sir. Appaji sir.
Namaste, Appaji sir.
Namaste, sir. Namaste.
Thank you, Dr. Padma.
Thank you so much, sir. Thank you.
For a very good program. Thank you, Anuradha madam.
Anuradha madam, thanks, everyone.
Thank you, thank you.
ಮೇಡಮ್ ಬಹಳ ಕ್ವಶನ್ ಕೇಳಿದ್ರು ಅದು ಥ್ಯಾಂಕ್ ಯು ಮೇಡಮ್
ಇಲ್ಲ, ಉತ್ತರ ಕೊಟ್ರಲ್ಲ.
ಕೊಟ್ಟಿದ್ದಾರೆ.
ಲಿಂಫ್ ನೋಡ್ಸ್ ಬಯಾಪ್ಸಿ ಇಲ್ದೇನೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ಬೇಡಿ ಅಂತ ಹೇಳಿದ್ರು. ಗುಡ್, ಹಿ ಗೇವ್ ಸಮ್ ಮೋರ್ ಟಿಪ್ಸ್ ಹಿ ಗೇವ್.
ಮತ್ತೆ ಇನ್ನೊಬ್ರು ಮೇಡಮ್ ಅವರು ಕೂಡ
ಮೈ PC ಅಂತ ಗೊತ್ತಾಗ್ತಿಲ್ಲ ಮ್ಯಾಮ್, ಐ ಡಿಡ್ಂಟ್ ಗೆಟ್ ಯು.
ಇವರು ಮೈ PC ಅಂತ ಇದೆ ಮೇಡಮ್, ತಮ್ಮ ಹೆಸರು ಅದೇ ಗೊತ್ತಾಗಿಲ್ಲ ಯಾರಿಗೂ.
ಮ್ಯಾಮ್ ಪ್ಲೀಸ್ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಯುವರ್ಸೆಲ್ಫ್. ಅನ್ಮ್ಯೂಟ್ ಮ್ಯಾಮ್.
ಮೇಡಮ್ ತುಂಬಾ ಕ್ವಶನ್ ಕೇಳಿದಾರೆ ಅವರು.
ಅನ್ಮ್ಯೂಟ್.
I'm Dr. Geraldine Sanjay from Bangalore. I'm in forensic medicine basically, and I'm in the pro-life movement. I worked in Victoria, Bangalore Medical College, and Bowring. So, as assistant professor.
Very nice, ma'am.
Is to join.
Thanks for joining. Thanks for joining us.
Because
Thanks for
cancer
joining.
and children is a really very difficult this to handle for families. It's quite difficult, and also rare diseases I think is another concern for families today. Children with rare diseases.
And one more question was asked about the support system that's available,
Yeah,
Padma.
correct.
Support
Yeah, that's
Ma'am,
another
is
question you should ask,
psychological
sir.
support you mean to say? Psychological or?
Yeah,
No,
because
financial.
financial and also for the parents, to handle
Counseling.
children
Ma'am,
with
Kidwai, it
special
is
needs.
Ayushman Bharat and it is quite free, ma'am. It depends upon only a few cases where they need extensive
Yes.
treatment medications they use. That's it. Otherwise, it's absolutely
True, very true.
Now,
Kidwai.
Infosys building has come up in Kidwai. Earlier, Zindal building was there. Kapoor's block is there.
Block
There are
for
3
children.
blocks for exclusively for pediatrics. So they can go approach Saran madam. Post-retirement, they again, they have been reappointed, ma'am. Dr. Appaji Gowda and Dr. Aruna Kumari. They got retired probably 5-6 years ago. Again reappointed and they're still working, ma'am.
Dr. Padma, this is where the alternative systems will come in, nutrition and all that. Finally, you have to, so
They
like,
take care. The dietitian is there, they take care. Even psychological counseling is there, ma'am.
okay.
They do psychological counseling to the parents. There is separate entity for that to handle, talk to the parents and relatives.
Okay,
There is separate.
Yeah. So that means the psychological support and financial support
Yes,
well
yes.
taken care at Kidwai.
Yes, ma'am. At Kidwai.
Yes,
Yes,
I
Kidwai.
agree. It's
And
yeah.
when we look into that financial or when the data as such, extraordinary, ma'am, as I told you, is patients have become professionals having normal children. Their children, the second generation, I mean to say. So much of credit they have got, like feather to the cap.
But Dr. Padma, that one point, when you were saying normal children,
In
and
the sen-
we should also, as doctors, help people to understand that imperfection or disease is not the, end point. Because so-called normal children are getting, committing suicide, being in forensic medicine, I'm real 34% children are missing. And, there are a lot of children missing and abused and all sorts of things are happening. So that is why my concern, that is why I also came.
Normal in the sense like genetically few diseases are there, no ma'am, in leukemia, other cancers.
But failure, I mean,
normal antandre, they're not suffering from any cancer, oncology.
yeah, but then I know, but I mean, of course, I think Dr. Anuradha knows, I've been dealing with the MTP Act. So congenital diseases, you kill the child, So this fear, when the child is not perfect, or we have to help children also deal with failures. A quota will know as to how many children are committing suicide early. The pressure on having a perfect normal child